important. If you look across the country, the highest incidence of uninsured populations are in New York, Illinois, Florida, and the Great Southwest. Some of that is perhaps understandable based on migration patterns. Some of it is understandable based on industry that drives the economies in these areas. But we cannot speak about this problem as being a problem of the United States in general. This is a problem that varies tremendously region to region. And certainly the issue of income, not a surprising factor, but the numbers are surprising. For people whose income is in excess of $50,000 per year, 8.6% of them are uninsured. So we are dealing with a population that largely works, but we're dealing with a population that has some limitations to their resources, to their means. And then we're dealing with these other factors such as racial issues that have a very, very complex interplay. So this is an incredibly complicated issue. And we can spend a great deal of time dissecting those factors, but we only have a single relatively short session. So let me turn to some other questions. I think there's an obvious one. Why are we really concerned about this? And I'm going to touch on a few different issues with you that I hope give you a somewhat more in-depth understanding. At a philosophical or an ethical level, we're concerned about fairness and equity. And that's a theme I will be returning to and actually closing with. So we are all troubled by the fact that people do not have insurance because we link insurance with access to the healthcare system. There are, as we heard, some individuals who do not carry insurance because they have the means. I will tell you from my experiences in the insurance sector and in the hospital sector and in the practice sector, those who truly have means generally have insurance and they expect you to accept their insurance. So it's not quite as simple as simply having means. The second issue, which is important, the first one I'm going to come back to again in a few minutes. Second issue is particularly important. Lack of insurance is very strongly correlated with a delay in diagnosis and an increase in treatment burden, in disease burden, excuse me. Let me give you just a couple of facts. If we look at a population that needed care but did not receive it, this is through the Community Health Survey of New York City just a couple of years ago. Patients needed care, felt they needed care but did not receive it. 31% who answered affirmatively had no coverage and only 5% had private insurance. You'll see the public insurance population in the data that I'm going to show you usually somewhere in the middle. Now remember, that's state and it's federal programs, tremendous heterogeneity in government programs. So there's more difficulty, and I will leave it at that, in getting access to care. Did not have a personal doctor. 60% of those who were uninsured versus 21 to 31% of those who had insurance. Some simple measures of how accessible the healthcare system was to this population. Now the questions that I ask on this slide force the numbers to look different. So a low number on this slide is bad, while a high number on the other slide was bad. Now let's look at treated hypertensives, patients with hypertension who had their blood pressure checked. Something obvious. If somebody is being treated for hypertension, their blood pressure should be checked. 26% for those with no coverage versus 63 to 58% for those with various kinds of insurance. Something as simple as having cholesterol checked. Only 49% of those with no coverage and 68 to 78% for those with coverage. These data can become very repetitive, because regardless of which indicators we look at, whether it's process measures such as these or outcomes measures, we are looking at a patient population that is not seeking or receiving the care that they should receive, and they therefore are coming into the healthcare system with an increase in disease burden. So that's yet another concern. Now, I said to you early on, and I will say by way of apology, that one of my major concerns, not just because I went to Wharton, but because it's my role, is to make certain that the business aspect of healthcare is managed well. This patient population imposes a financial burden on providers. It imposes a financial burden on physicians and on hospitals. We are, in fact, obligated, not just because of the ethics of healthcare, but because of federal and state statute, to take care of patients regardless of their ability to pay when they cross our threshold as an institution. And that is something that most institutions do very proudly. But in fact, this is a patient population, because of the burden of health care, because they've had a longer period of time before being seen, that in fact carry a significant increment in the cost required to provide the care to them. And that actually passes a financial burden on to all of us. So there's an economic side. So we're dealing with a philosophical aspect to this problem, we're dealing with an ethical aspect to the problem, we're dealing with a burden of illness problem, and we're dealing with an economic problem. So it has multiple aspects to this. Another question I think we should ask is, why are there so many uninsured? And to start with an answer to that, I want to remind you that we are living in a country whose health insurance system is employer-based. Now, let's just look at this for a second. 62% of Americans have their health insurance provided through their employers. Then, of course, we have the long and growing list of government programs, including Medicare, that has effectively taken care of the elderly and the disabled. It has its problems, but that's not the focus of our discussion today. We have Medicaid, we have Family Health Plus, we have Child Health Plus, we have a number of programs intended to serve as safety net programs for various populations in need. And then we also have individuals. We have many individuals who are self-employed who elect to purchase their own insurance. What they discover is the very nature of insurance, which is really a risk mitigation function, spreading risk, and what they discover is that as individuals, they cannot engage in risk spreading, so they pay the highest premiums. That's the nature of the insurance industry that we have embraced. Let's not forget that our employer-based system has evolved over the past 50 to 70 years. Some of you may be aware that that employer-based insurance or employer-based health benefits were allowed following the Second World War at a time that there were wage and price controls. So it became a very attractive benefit that were allowable under these rather restrictive guidelines. And it's become so embedded into business and tax code and regulation that it's actually quite difficult to unravel. But that serves as the basis for our insurance system. Let's not forget something else. There's something that Americans cherish. We cherish choice. We want a selection of various programs. We want to mix and match. We want to customize. And that has actually also promoted the diversity and the competition in an insurance industry that drives many patients, physicians, and hospitals